Well, hi, folks. Happy New Year. Welcome back to our AI4C, Artificial Intelligence for Clinicians lecture series. I'm Kathy Andriel from Brigham and Women's Department of Radiology and the Mass General Brigham Data Science Office. And we're thrilled to have Dr. Nina Kottler here today, who's going to talk about the tech-enabled future of radiology, bridging the gap to a new era. And we apologize about last month's cancellation. There was had a personal issue with the speaker. We're going to try and get her back to give it another time, but this is a great way to start out the new year. As you know, these are the second Thursday of the month, September through May. We take the summer off, and we have a great lineup of speakers here, starting with today. And then in February, we have Dr. Jagmeet Singh, who's written a textbook about the future of medicine using robotics and AI. We have Krishnan Jularu, who's with the FDA Digital Health Center of Excellence. He'll talk to us about what's going on there. A wonderful young scientist, Paul Yee from University of Maryland and their Medical Intelligent Imaging Center. And then Mike McNick-Gray, who's out at UCLA and a longstanding researcher in the field. Remember that you can go back and review past recordings. As you like, they are available to review. And we do ask that you please fill out the survey. Carrie Ann has put a link to the survey into the chat. You can, as I mentioned, watch AI4C anytime, and these are the links. You can go to our website, look at educational activities in the AI4C, and you can follow us on LinkedIn and Twitter and so on. So let me introduce our speaker today. Dr. Nina Kottler received a Bachelor of Science in Mathematics from Emory University. She got a Master's of Science in Applied Mathematics from North Carolina State University, and then her MD from the University of Massachusetts Chan Medical School. She completed her diagnostic radiology residency at the University of California at San Diego, and she received a number of awards there for excellence in research. She's been a practicing radiologist for more than 18 years, specializing in emergency imaging and teleradiology. And she's the first radiologist to join Radiology Partners. She's held multiple leadership roles with that organization, which is a wonderful, huge organization. And she is currently the Associate Chief Medical Officer for Clinical AI for Radiology Partners, and also Vice President for Clinical Operations. Dr. Kottler's an associate fellow at the Stanford University Center for Artificial Intelligence in Medicine and Imaging, the AIMI. She's a population health subcommittee chair for the American College of Radiology Data Science Institute and a member of the Radiological Society of North America Radiology Informatics Committee. She's also on the SIM, which is the Society for Imaging Informatics and Medicine, the SIM Machine Learning Committee, and she's the AI industry liaison for that. She's also a member of RadXX, which is now a Rad Equal. She's on their steering committee. Combining, as you noticed, her experience with applied mathematics and medicine, Dr. Kottler has been using technological innovation to drive value in radiology. She's been issued a patent for a natural language processing driven software tool for real-time clinical decision support for radiologists around optimizing population health and best practices around follow-up guidelines. She's a passionate speaker. She's passionate about promoting diversity and creating a culture of belonging. And as an industry expert, she consults for companies in aerospace, in material science, and in healthcare. And she's a frequent international lecturer discussing imaging AI. So we're very fortunate to have her today. She's going to talk about the tech-enabled future of radiology, bridging the gap to a new era in AI. So thank you so much, Nina. I'm going to stop sharing my screen, and we look forward to your talk.
Thanks, Kathy. Thanks so much for having me. I am going to just bring up my PowerPoint right now. And let me get us started. Okay. Well, you had that great introduction. I'm not going to even repeat the title of the talk. The whole point is that AI is going to be a part of what we do every day. And the more we learn about it, the better enabling we are our specialty and our patient care and the future of healthcare in general. So I have a few disclosures. We're going to talk about three things today. First, I'll give you a glimpse into how I think about the future of radiology. We'll talk about some lessons learned in our practice. We've been using AI for a long time. And then we'll finish up going through some of the things that we need to do in order to get AI to be standard of care, which is essentially setting up best practices. And I'll go through one of those, which has been one that I found to be most helpful for audiences, which is how do you choose an AI model to use? There's multiple out there now. How do you clinically adjudicate them, figure out which one's best? Okay, I'm going to start with the first two sections sort of combined together. And I know you guys have all seen this, so I'm going to go through it quickly, but I wanted to not give as grim of a prediction as Jeff Hinton. I tend to be a very optimistic person, and I don't believe what he said in that, we're like Wile E. Coyote and we should just stop training radiologists now. That was 2016. He did come back again in March of last year and insulted us again, sort of, saying that what we did could probably be done by a highly trained pigeon. And then in October, he was on television saying that what AI can do today is already comparable with radiologists in its understanding of what's going on in medical imaging. And that can be very scary. And that's a lot of the stuff that brought up the hype. I mostly disagree with everything he said. There's one component of what he said in March that I agree with. And that's that the role of radiologists will evolve from doing perceptual things to doing far more cognitive things. And I think we have to be realistic. In the beginning, when in 2016 through 2018, I'll say when there was massive amounts of hype from the convolutional neural networks, people were really scared. And so the answers to questions of what's going to happen in radiology were like, don't worry, nothing's going to happen. And that's not the case. We are going to evolve just like we always have evolved. But what is that evolution going to look like? And for me, we have to think about that because we're not going to get there automatically unless we have a vision. So I'm going to show you my vision that I crafted a couple of years ago. It's maybe a little bit out of date, but I want to start with this because I think this is the idea of where we could go. So imagine that Tom Cruise here is a radiologist. All right, this is just from one of his movies, Minority Report. And the imaging itself is not that important. But what's important is that right now we evaluate medical imaging. We have additional information that we're starting to get, some of us anyway, structured information being added through artificial intelligence, right? That's what AI does. AI adds structure to our unstructured data, both medical imaging and reports and clinical data. So we get additional information from AI. The problem is the way that it's been implemented today is it's been implemented kind of on the side. You can't interact with it. In the future, we're going to be able to interact with the AI. We know AI is not always right. Sometimes it's incorrect. We as physicians and as experts in medical imaging need to be able to interact with the structured information coming into our field, make changes. As we make changes, the AI should run again, provide updated information that we can then take and combine, provide that context back to our referring clinician. Now, AI is just one of the areas where information is going to be provided. We're already starting to see a lot of other arenas, molecular imaging, radiomics, genomics, proteomics. There's probably about 10 or 15 different areas. And then we get into areas where patients are wearing wearables, right? The Internet of Things. Massive amounts of data are going to be coming into the system. And when I first started in radiology, when I was a medical student, there was no PACS. It was a long time ago. So everyone used to come down into the reading room. That was the first thing they did. And they would talk with us as clinicians to get information about their patient and know what to do next, right? We're the clinician's clinician as a radiologist. That's always been our role. And I think what we do in the future is we start expanding that. We're expanding it already from just looking at morphologic imaging to adding structured information from AI. We're going to, in the future, add structured information from other places, combine all of that together, and then provide that consultation back to our referring clinician, perhaps the patient, to explain what is going on and contextualize all of this information together. That means we're going to transform from what I call us now as the imaging expert to an information expert. Now, this is one possibility of where we go in the future. If we are going to get from here to there, we need something to help us, right? We are overwhelmed with the current amount of just imaging data that we have to get through, let alone AI, molecular imaging, all of that other stuff. We can't fit it in. So in the future, what's going to happen is more and more of this AI and other technological innovations are going to make us far more efficient. And as they make us far more efficient, we're going to be able to elevate our role. We'll have more capacity to do the things at the top of our license and even beyond where our license goes right now into these other worlds to combine this information, take it so that we're not just looking at morphology, but we're putting that in terms of population health and then extending that into precision medicine. So this is what Jeff Hinton said that I agree with. We're going to move from perception to cognition. All right, so now if you have a vision, regardless of what your vision is, you have to make it happen, right? It doesn't happen automatically. And so I thought about what are the things that I want to do in my organization to get us from here to there. And I came up with these 6 things, and I'm going to talk about one of them right now to get us going. So in order to move forward, you need to have experience in utilizing these tools. A lot of research is being done in AI, and people will speak about the research that they're doing, but I find that that information is lacking in understanding how we're interacting with it. When you actually go to deploy these things and you go to deploy them at scale, you just run into a whole nother set of issues that are hard to resolve unless you know them. And in our practice, we've had a lot of experience working with AI. We started in 2015. And now this was data from early last year, so it's already out of date. But we have run over 30 million exams or processed 30 million exams by some kind of imaging AI, like a convolutional neural network. We have run over 115 million exams through a natural language processing AI. And we've got 2,300, it's actually probably around 2,800 of our radiologists now are exposed to some form of AI. And they might be using one of the AI tools, or maybe they're using multiple, but being exposed is what gives you that experience. With that, I want to go into the second phase of our talk, which is to talk about some of the lessons that we've learned through the actual deployment of AI. So lesson number 1, AI helps us find unexpected findings. In the beginning, when we deployed AI, I did not have a big team. It was mostly me, and we were running it as a pilot, and we decided we're going to run, after we ran our initial pilot and the accuracy was good enough, we were going to sort of roll it out across our practice, but in the background. And when we ran it in the background, I got to adjudicate any case where the AI said that there might be a positive finding, but the radiologist report didn't say that. And I looked at all those cases. It was tons and tons of cases, and that's where I got a lot of this information from, consolidating that into lessons. And so here's an example of a 50-year-old male, and the history was literally suspected PE. It's actually a great history for us because we know what they're looking for, and it helps direct us to look for a PE. However, there was no PE in this patient, and the real history was chest pain, and the cause of their chest pain was identified by one of the AI systems we were using, which is detecting rib fracture. Now, the rib fracture detection model and any of the models, they're not looking at the clinical history. So they're not biased by that history. They're just looking for rib fractures. And they found this anterior rib fracture that, frankly, we miss quite frequently. They're very hard to see, even when you're looking specifically at the ribs, or if you have a history of trauma, they can be quite difficult to see. And there was no PE. Both the radiologist and the AI model for PE agreed, no PE, that wasn't the cause, but there was a cause that we didn't identify. And I think that's because we as radiologists in this case were biased by the history that we were given. Here's another example of, let me just move my screen so I can read this. Well, I might not be able to, oh, here we go. 56-year-old male with left flank pain. And here's a CT of the abdomen and pelvis on the left. There's left-sided hydro and stranding. So you see the cause for left flank pain. There was an obstructing distal left ureteral calculus. Awesome. We feel really good about this because we gave the answer to the clinician's question. However, what the clinician didn't ask or mention was that there were other findings. The patient had free air, tiny, tiny foci of free air. These foci of free air you're not going to see unless you're on lung windows. And a lot of times you're not going to look at those unless you have some history of trauma. So this was missed. And I think in this case, we were biased by satisfaction of search and also some patient history. Here's a 52-year-old male with shortness of breath. This was back during the Delta wave of COVID pneumonia, and this is what COVID pneumonia looked like. And it was great. We diagnosed that, but what we missed was this small, isolated subsegmental pulmonary embolus in the right lower lobe. And this was picked up again by the AI. All of these are examples for things that I found during our background evaluation. And there were a bunch of examples like it picked up by the AI, not by the RAD, because there was a lot of other distracting pathology. It's very hard to see the subtle findings when you've got COVID pneumonia. Here is a 66-year-old male with altered mental status, came in for stroke. So what do you get? You get a CTA of the head and neck. And on the left is an example of that, a sagittal image. And when you're looking on the axials for stroke, you're looking for occlusion, which means you're looking at the blood vessels. And anterior and posterior circulation blood vessels are circled. They're very centrally located within the image. However, the image was not cut off like this. And what we didn't mention was the cervical spine fracture in the posterior elements, one of those things that you're not looking for. And they're going to be very hard to see in this instance because we're biased by the exam that was selected. And we have to concentrate on certain things to answer the clinical question. We tend to miss these other things. AI, again, picked this up. Here's a similar case, 47-year-old male with subarachnoid hemorrhage and headache. This is a non-contrast head CT, and you can see that there's hydrocephalus. The temporal horns of the lateral ventricles are dilated. There's subarachnoid hemorrhage. That's the white in the center of the study. And when you get this kind of exam, young patient, the cause of this is generally a ruptured aneurysm. So the next case that you're going to get is a CTA of the head. And the most common location for an aneurysm is going to be the circle of Willis. So we concentrate as radiologists, we've had our education, we concentrate in these locations. There was no aneurysm in the circle of Willis, and we did not find one, but the AI is not just looking at the circle of Willis, they're looking at all of the images that we're sending in, and they found this 5-millimeter aneurysm coming off the left pica, low down at the skull base. Really uncommon location, but we actually had 2 of these in our cohort of patients that were identified that we missed. And another case where this is something that we're biased by an uncommon location. So let me talk about bias a little bit because I've been presenting bias in a way that we recognize that humans are biased as well. And there is a positive component of bias when you combine 2 systems together. So let me go through that. I always learned in residency that the highest quality combination was me as a very early year resident plus an attending. And as an early year resident, I really knew very little. But the attending knew a lot. And the attending could take a look at everything. And because the attending had very specific education and experience, they're looking more closely at certain areas on the image than I am. I don't know where to look yet. I'm an earlier resident. I'm starting to learn that. My patterns aren't developed. And so I'm looking everywhere, maybe at least at all the bones and maybe not in all the right places. So I may overcall a lot of stuff that the attending might not see. Maybe some of those things are going to be accurate. And then the attending can say no to all my false positives and yes to the, every once in a while thing that I might point out that's useful. And then the 2 of them together, we form this really nice, accurate system. But not everyone can have this. We can't afford to do that across the country and across the world. But what we could do is have radiologists with AI. So you have your experienced radiologist looking in certain locations. You have your AI that's looking at every pixel, or if it's 3D image, it's looking at every voxel. And then it, based on its education, everything that it has been taught, it is looking at certain areas more specifically. And when those areas don't overlap exactly, that's when you get the benefit of additional sensitivity from one system to another. And what we found is in doing a lot of this adjudication, we looked and found that AI was able to improve the radiologist sensitivity. Now, this was data from a brain aneurysm model that I'm going to show you later. So you'll see this data later. But if we looked at how many additional cases the AI identified that was not in the radiologist report, it was 24%. It's a very big number, really helpful, and that could boost our sensitivity. Now, it's not just one-sided. If you look at how many cases the RAD identified that the AI didn't, it would have boosted the AI sensitivity by 34%. So you can get a really nice boost in sensitivity with these models when you put them together in an optimal way. All right, that was lesson number 1. AI helps us find unexpected findings. And that's because I think radiologists and AI have different underlying biases, different education, and we can augment each other. Lesson number 2, AI helps find subtle findings. So what are most of the things that the AI found that we missed? Well, they tend to be really subtle. And these are examples. They're all subtle. So I put in the heat maps, the probability maps, because even when you see them on the big screen, that they're hard to see. So the question is that helpful? I mean, ultimately, it's nice to have more findings, but if those findings are not helping the patient and they're not providing downstream value, and you can imagine a case where you might overcall, or you might call appropriately a bunch of really tiny subarachnoid hemorrhages or subdurals or some other kind of parenchymal hemorrhage, you finding things that you didn't find before, and then all those patients get treated, or they all go into the hospital for inpatient stays. And then we add a lot of costs to the system. But some of those patients are going to be fine and it's going to resolve on their own, and some of them are not. And I think where we need to go in the future is use AI to help us triage. Take in more information than just the imaging information, but add the clinical information, patient history, and then help us triage which ones are going to be needing more care and which ones aren't. In the meantime, I will suggest, because when I go and train people about using AI, a lot of people dismiss, they're like, oh, it's just going to find subtle things that don't really matter. These third branch PEs that I don't really care about, no one treats. Well, I will tell you already anecdotally that you can't just bypass subtle findings. So here was an example we found pretty early on. This was a 72-year-old female, came in with altered mental status. And this is when we were running AI in the background. And we didn't pick up this really subtle subdural hematoma, really subtle along the calvarium. The AI found it. I took a look at it, said, I think this is real. We contacted the emergency department and they called the patient back in. Now, it took the patient a while to come back in. One, because I guess they weren't having symptoms, who knows, but 36 hours later, they returned and they had this much bigger subdural hematoma, so big, in fact, that it was causing mass effect on the brain, midline shift, compression in the left lateral ventricle. And at this point, the patient had to be treated with a craniotomy, much more aggressive treatment than if we had watched them and seen this grow more slowly. And this, I'll tell you, was something that was clinically unexpected. The patient had no history of trauma. They were not on Coumadin or other blood thinners. And the patient themselves didn't return because of their own symptoms. So we can't always predict just based on looking at a finding and saying it's small that it's going to be something we can ignore. Again, we're going to need AI and other tools to help us predict which ones are going to be important, but we can't ignore them. So, so I will say that AI, if you look at any kind of AI system, it's not necessarily going to provide the same value. The value of AI is really exponential once you get past a tipping point. So what do I mean by that? The value is here in the blue box. If you have an AI model that is not that sensitive, maybe let's say 50% sensitive, then it's going to pick up findings that are fairly obvious, stuff that you're going to pick up anyway, not a huge amount of value. The value only comes when it's picking up stuff you're not picking up. And that does not come until you're finding things that are pretty subtle and hard to see. So you need a much higher sensitivity of a model in order to do that. Now, again, I've just talked about sensitivity. None of these things are one-sided. If you look on your ROC curve, as you increase your sensitivity, you definitely have a likelihood of decreasing your specificity. And if you do increase your specificity from 90 to 95%, you're going to cut your false positives in half. It's definitely a balance, but I will say that you should be looking to use a highly sensitive model. They're not all created equal. All right, lesson number 3, AI may help detect findings that humans cannot see. And this is where it starts to get really interesting. So this was a case that I was really shocked by. This is a 70-year-old male, came in with right-sided paralysis and word salad. So we're looking in Wernicke's area for a stroke in the left temporal region. And we, on the left, have the 2D image, or just one slice of the head CTA. So this is post-contrast. So anything white is contrast in the blood vessel. And then on the right is the 3D reconstruction of that CTA. And for us as radiologists, the M1 and M2 segment, we're looking specifically on the left because of the symptoms. They should have a left MCA stroke. We didn't see any cutoff. There was nothing that was a contrast cutoff. The M1 and M2 segment, even M3 going up, they all looked fine. What's interesting is that the AI was looking at these images. They didn't get any other images. They just got these axial slices from the head CTA, and they called a large vessel occlusion. They called a abnormality in M1 that we couldn't see. Now, luckily, we had the non-contrast head CT. And if you look on the non-contrast head CT, you can see a focally dense left MCA sign. And that circle, the area that's circled, that density is on a non-contrast study. That means that there's clot in that vessel. And the clot in that vessel was small and the same density as the contrast, and we couldn't see it at all on the post-contrast study. We could see it here on the non-contrast, but you could imagine a case where the AI is picking up something that we're not. And here's the perfusion exam. There was a stroke, left temporal region, that explained the word salad and the patient's symptoms. And that was something that we would have had trouble picking up on the CTA. Here's another example, 80-year-old male with shortness of breath and chest pain. They were looking for PE. Now, we tend to look at a certain standard thickness slices. And sometimes in my practice, we're not just academic medical centers. We do have some of those, but we also have community centers. We've got all kinds of different urgent cares and individual physician sites that send all different kinds of data. And you may not always be getting the thinnest slices. They may be doing them, but you might not always be getting them. So here's 2 millimeter slice thicknesses on the right. Really hard to see what is a pulmonary embolus in this. That's easier to identify in the 0.6s or 0.625s. Now, it's still hard to see in general, but we always send the thinnest slice images to the AI. The AI should get those. Now, if I told the rad every time, go back and always read the thinnest slice images to see if you're going to pick up and find these things, it might not be the best use of their time, but I'm always going to send that to the AI. Here's another example, 50-year-old female with right-sided rib pain. Even knowing where to look, it's hard to find this rib fracture on the 3.75s. A lot of the images that we get are 5 millimeter slice thickness in the abdomen in some of our locations. And so you may not have the 1.25s, and that is a lot easier to see in the 1.25. Still really subtle, but you always send those to the AI. So lesson number 3, AI may detect findings that humans can't see or are difficult within the slices that we're actually looking at. And that gives us an idea of how we're going to move forward working with artificial intelligence. Lesson number 4, RADs can improve AI accuracy. So it's not one-sided, and I'll just show you a few examples of things where it's pretty obvious that the AI is missing. I found a ton of these. I'm just going to go through a few. So number 1, we have to dismiss the false positives. Motion artifact on these non-contrast head CTs causes that streaking. And in all of these cases, the AI was calling intracranial hemorrhage. Easy for us to dismiss. I don't mind when I get a false positive that's so obvious like this. Where it's more problematic for me is when it's giving me a false positive that I might also call. And I have to really think and adjudicate a lot harder. But this one is pretty easy. Here's a 47-year-old male with diffuse abdominal pain. This is a post-contrast CT scan of the abdomen and pelvis, just looking at one of the axial slices. And we send all the axial slices to AI for these abdomen studies to look for free air. And in this case, it called free air. That little focus right there, centrally on the right in the mid-abdomen within the mesentery, was called free air by the AI tool. Now, for us, in any individual image, that could potentially look like free air, but we as radiologists, we don't look at an individual image on its own. In general, when you're looking at any kind of 3D imaging, you're scrolling up and down, or at least I am, and I'm following the bowel. And in this case, it was just gas in the tip of the appendix. And there were several different examples like this. There were gas and diverticuli. There were gas in a little edge component of the bowel that was a knuckle that was sticking up into one slice. And it looked like a little bit of free air. And the AI would call that as free air. Whereas we were following the bowel, it's a lot easier. We're looking in 3 dimensions. The AI is not. Most AI is trained and is getting only 1 dimension, and it is not looking in more than 1 dimension. It might be looking at more than 1 slice at once. It looks at a voxel of slices, but not nearly as many as we do. And so this taught to me that really AI in general is not looking at anatomy in 3D, and it's going to make mistakes because of that. Now, in the future, that will not happen, right? We'll be training these on 3D imaging, but right now, this is the case, and we have to be aware. And when I go out to tell my radiologists about how to properly consume these tools, I educate them significantly about the areas that the AI misses. Here's another case. A 93-year-old male came in after a fall, C-spine, looking for C-spine fracture, and the radiologist picked up 2 C-spine fractures. The AI picked up 1 of them. And this is the one that the AI didn't pick up. So why didn't the AI pick this one up? Generally, the AI is looking for a lucency between bone and another piece of bone to see that that's the fracture. That's how I've seen most AI be trained. They're looking for that linear lucency. Well, this has a clear linear lucency. It's pretty obvious that there's a fracture here, especially when you circle it. But we were sending the AI the sagittal images. AI is generally only looking at 1 series. You might think it's looking at all of the images that you're looking at. It's not. It's generally getting 1 series of a 3-dimensional exam. So in this case, C-spine fracture was trained on the sagittal series. So we send it the sagittal series. Now, what is sagittal looking at? I'm going to make lines to show you how the sagittal imaging is seeing things. So each line is a slice of sagittal imaging. And you can see that it goes from yellow lines of seeing bone to a red line of seeing no bone to a yellow line of seeing bone. You're not seeing the lucency cross the sagittal slices because the fracture is perfectly aligned in the sagittal plane. Very hard to see. If we were looking at the sagittals, we would miss this every time. And the AI as well, right? AI is looking at sagittals, the AI missed it, but the radiologist picked it up because we're looking at things in 3 dimensions. Here's another example, 65-year-old female with headache. This is a non-contrast head CT. We sent this through the intracranial hemorrhage model, and it picked up this area, rounded area of increased density, which I would want it to actually pick up. I mean, I looked at that and I'm like, well, could that be hemorrhage or is it calcification? Hard to know. But I had a prior, and the prior showed me exactly the same thing. In general, right now, most AI models are not trained on the priors. They're not looking at the priors. Now, you could send it the prior independently and have it check out both, but it's not adjudicating the current exam based on the prior results. And so you're going to get a lot of false positive just because there's something that we know is chronic, but the AI doesn't know because it's not even getting that information. And we find this a lot on AI for mammography and tomosynthesis, where we're looking at lots of prior studies. The AI, some of them are not. There's one that is cleared for utilizing prior images, but you have to ask and see, is the AI looking at priors or not? Because otherwise you'll have to do this adjudication yourself. So lesson number 5, this is the most important lesson of the day, is that radiologists and AI are better together. So let's go back to that very first example of the 50-year-old male with suspected PE. Now, the AI did a great job and helped me find this rib fracture that was the cause for the patient's symptoms. And in our report, we didn't report anything. But when I got this case, I took a look at it. I went back in, looked at the original images. And because now I was thinking about rib fractures, I wasn't thinking about PE. I wasn't even looking for PE. I was just looking at rib fractures. I found 3 additional really subtle rib fractures that the AI didn't find, and that I'm sure I would not have found in looking at this exam the first time. So with the AI directing me at a finding, there's a part of our brain and a physiology of our brain that we call priming. That if you prime your brain to see something, you can be much more accurate in finding that finding. And this is a concept that was really interesting to me about how we can improve each other, or at least the AI can help us improve. So if you go in and the AI finds a finding, you are now going to go back and look more specifically for that finding, not for the 1,000 things that it could be on this chest CT, but for rib fracture and complications of rib fracture. And I found this not just for the rib fracture model, but for every single model. The AI will point out one, and I can often find more. So I teach my RADs to go back when the AI's found something, take a look at that thing, look for other subtle things. You're going to find it more easily because your brain is going to be primed looking only for that. And look for consequences of that. We found subtle pneumothoraces. We even found big pneumothoraces, or I think maybe they just didn't look at the lung windows or something. We found pleural thickening, pleural effusion, other components that are going to happen because you're also finding this finding. So to me, integration is the future. Radiologists, we're measuring radiologist accuracy on its own. We're measuring AI accuracy on its own. It's valuable, but it's not how we're actually deploying them. We're deploying them together. AI is not autonomous. AI is used with the human user. We should be measuring the accuracy of the two together. And what we want to do is we want to get back to where we can augment each other and where we can increase the accuracy of one over the other. Now, that's not always going to happen, and we'll go into that a little bit later, but here's some of the things that I found were useful that the AI could do, and I could rely on the AI to do these more than I can rely on myself, and then things that I would necessarily need to rely on the human to do more than the AI. This is, again, based on the learning that we had. Now, remember, if we want to get ourselves to our future, we have to be more efficient. We have to be able to get through the stuff that we're getting today, plus a lot more. And we have a lot of learning that we have to do. That means we need more time. And if I went back and, like I do with peer review right now, and just said, hey, Rads, I noticed that we're missing right upper lobe isolated PEs in segmental and subsegmental vessels. I found that was actually one of the most common things that we were missing in for PE that the AI was detecting. If I went back and told my RAD, just look harder in the right upper lobe every case, I'd be wasting their time. And in fact, I might make them less good at finding other things because I'm distracting them. And it's not a common finding, but the AI is detecting it. So let's take the two together, take the benefits of both, and then we're going to be more accurate. Don't force your RAD to try to do these things. All right, so what is the goal? Ultimately, the goal is what I'm talking about. It's adding the two together. Now, we have done some of this evaluation. We've looked at, for all of these different AI use cases, how often is the radiologist finding a finding that, and how often is the AI finding a finding that the RAD isn't? So they're each helping each other, and you can add up to 100%, which is greater than we're doing on our own. So RADs in this case are the orange bar. This is how much we are detecting on our own. And the blue bar is how much AI is enhancing us. Now, this is an optimal enhancement, but let's try to get to this place. And in fact, I think we can get even higher than this, because what I showed you in the past, if we look at what the AI finds, we can then find more findings of that, right, through priming. Now, whenever you add a AI with a human, a bias is introduced. Now, this is the bad side of bias, which absolutely there is. And these are probably the things that you hear more about. And this prevents us from getting to that 100% or 110%. And these are things that we are going to have to educate the users about and actually implement other things in order to combat these. So let me talk about how I think about bias, the two different arms of it. So one arm is when the radiologist does not over accepts a false result from the AI. So those are automation bias and complacency. So automation bias is when the AI gives you a false positive result. And you as a user, we tend to be sometimes we tend to overtrust an AI system or a computerized system more than we trust ourselves. We don't even know we're doing it, right? It happened with other computer systems, like when we had GPS and people were turning the wrong way down one-way roads, and you ask them why, we're like, well, the GPS told me to do it. So automation bias is a real thing, and we have to protect against when the AI gives us a false result. We don't want to accept that false result. Complacency is the another end of that spectrum, where the AI gives us a false negative. It tells us the study's fine, nothing to worry about, and then we might get a little bit more complacent and miss a finding that we would have otherwise found. Complete other end of the spectrum is distrust. The AI gives us a true positive, a true finding, or a true negative. And we don't trust it, and we change the answer. And so all of these things lead to us decreasing from that accuracy of 100% to lower. Here's an example, an actual example in our practice of automation bias. So on the left, I've got a non-contrast head CT. Remember, non-contrast, there's no white, there shouldn't be any white in there. And there is a little bit, a white dot in the left MCA region. And we ran this through our brain aneurysm model. And the brain aneurysm model, while it should be looking at the post-contrast study, for some reason, the brain aneurysm model picked up this non-contrast study, and it ran the non-contrast study through its AI model. And what did it pick up? Well, it picked up this little focus of brightness. Now, it ends up that that bright focus right there was partial volume artifact with the tip of the sphenoid bone. It was a part of a bone. And you can tell that really easily if you're a rad and you're looking through it. You don't even notice this as something that stands out to you. But on this single image, it could stand out, and it stood out to the AI. The rad didn't realize that the AI was calling something from the non-contrast study. And so they reported the study and they hedged. And they said, well, there might be a left M1 aneurysm. This is automation bias. It's going to be really important for us to understand how the AI is thinking. If the radiologist knew that the AI had interpreted the non-contrast study, and that was really obvious, this might have been less likely to happen. There's a lot of work that's being done out there to figure out how do you decrease bias between human and AI. We don't have time to go into it today, but this is what we need to think about in 2024 and start implementing. Complacency is the other end of the spectrum. We've seen this quite a bit, where the AI in general has really high negative predictive values. So what does that mean? These are actually the negative predictive values of all the models that we've looked at and we've measured. They're all above 99%, and some of them are, almost 100%. Negative predictive value means when the AI comes back and says the study's normal, there's no finding for ICH, PE, IPE negative, then how often is it right? And it's really often right. Why is it really often right? Because negative predictive value is inversely related with disease prevalence. Disease prevalence tends to be low. There's not, in our population, ICH is maybe 5%. Sometimes it's only 2 or 3% of the time are we seeing ICH. So that percentage, if you take the inverse of it, translates to a really high negative predictive value. It's really easy in these cases to be complacent. And when the AI says, no, there's no PE, that we don't look quite as hard and we don't even recognize we're doing it, and we might miss findings we would have otherwise found. So this can be quite dangerous. This is complacency. The other end of the spectrum is distrust, and that just happens quite frequently. That might even be more frequent, where we're missing findings by combining the human and AI because we're not trusting the AI result. So we as users have to be educated in order to properly consume these tools. So how do you do that? I think that there needs to be more oversight about AI. And when we talk about oversight, people talk about only individual components. And I wanted to give you another way to think about how are we going to oversee AI in the future to make sure its accuracy, and not just the accuracy of the AI on its own, but the accuracy of the human user plus the AI is good enough. So these three components are sort of pre-deployment or real-time, in-use, and post-deployment. Pre-deployment, before you roll out something, before you're allowed to use it, many cases you're going through the FDA or some kind of evaluation. In our practice, we validate every AI tool, even if it's gone through the FDA, and we're looking for accuracy. Now, I will give you a little point in that when something's gone through the FDA, they're looking very specifically for what we call efficacy. And efficacy is different than effectiveness. Efficacy means, is this safe in a kind of a lab environment? If you have a good environment where you're going to deploy these, is this going to be patient safe? And but that's not how we deploy things. Like, healthcare is messy. And what you need to do, and what we do in our practice when we look at every AI model, is we're looking at on our data in our environment, and that's more looking at effectiveness. How effective is the AI at being accurate in our clinical environment? It's a very different evaluation, and I'm going to go through a 5-step process of how we do that. That's before you deploy. You also have to look at real time to mitigate bias. How is the RAD plus the AI doing as a system? And then post-deployment continuous monitoring, because these tools over time will change as the data inputs change and the accuracy will fall off. All right, so let's look at this component. I'm going to start to go a little bit faster. This is the last part of our session where we talk about best practices. So why do we want to create best practices? If you're looking at this Gartner hype cycle, and Gartner is an information technology consulting firm that puts out this curve that talks about the maturity of any new technology. And in this case, I'm talking about AI within healthcare. And we are actually probably a little bit lower than this now. This was a bit of an old slide. We are coming through supplier consolidation, probably down to the trough of disillusionment with sort of the NLP and convolutional neural networks. But in order to get to the plateau of productivity, we have to have best practices. We need things to be more plug and play. Everyone can't be recreating the wheel to figure out how to do this. And so you need to have some people who are early adopters who are creating best practices so that other people can deploy them more easily. And when you think about best practices, you got to think about, well, I think about the life cycle of AI. And in all of these areas, we should be creating a best practice. I'm just going to be talking about one of them right now. And that is, how do you clinically evaluate a model to know if it's something that you want to use or to know which one you want to use? So let's go through that. But I will say that what you are told by the vendors or any single number like the AUC is useless. I don't look at any of that. So let's go through what we do look at. So we evaluate AI model performance using a 5-step process, looking at performance statistics. We look at enhanced detection rate. We look at wow cases. We categorize the AI pitfalls, and then we summarize and decide. So I will go through that with you with 2 examples. But if you are coming up with a way to measure something, you have to decide what your measuring stick is. How are you determining that that measurement is good or bad? And we look at it through a lens of radiology acceptance and engagement, user acceptance and engagement, because you could have the best tool in the world, highly accurate, really great. If rads don't like it and they're not going to use it, then it's worthless. So looking at it through this lens is a very different lens than the FDA is looking at it. It's a different lens than vendors are looking at it, but it's the lens that if you're a user, you should be looking at it. Okay, so let's go through 2 examples. This is the brain aneurysm CTA model we validated that I told you about a little bit earlier. So this is, first you have to know what it's doing. It's analyzing only the head CTAs, and it is looking at the axial slices. It's only for adults, which adults in this case is defined as 18 and over. So here are step 1, we evaluate model performance. We do look back at the FDA clearance statistics, and here's the data. But then we create our own. We run the model through our own data, our own images, and our own reports, and we adjudicate, and we get a real world sort of practice validation. And in our practice, we're in all 50 states, and we have really variable data. So what we look at is hopefully something that is valuable for all of the constituents in our practice, because we can determine how generalizable the data is. Now, there's a few differences between what we do and what is done for the FDA. Number 1, we're looking at way more cases. Why is that? It's because we want to look at a natural disease prevalence. So for brain aneurysms, in this case, prevalence in our population across our practice was about 5%. Out of all of the post-contrast CTA of the head, 5% of the time was there a brain aneurysm. Now, if you are putting in information for the FDA, generally you are augmenting your disease. And in this case, they augmented it. They said it was 36% was disease prevalence. Why do they do that? Well, it's because you can analyze less cases and still find enough positive findings. We want to look at a natural prevalence because we know natural prevalence, it affects your positive and negative predictive value. And when we're looking at it from a lens of a radiologist acceptance, that's what we care about. That's what we see. Sensitivity and specificity, I've talked to you about that. I want you to understand it, but it's not how a rad perceives the output of a study. We have no idea what the sensitivity and specificity means. We know what the positive and negative predictive value is. We're getting a result from the AI. How often is that positive result right? That's positive predictive value. We're getting a negative result from the AI. How often is that negative result accurate? Those are the things that a radiologist looks at. And again, they are very dependent on disease prevalence, so you have to understand that difference. Now, it's not just disease prevalence that positive predictive value is related to. Positive predictive value is also related to specificity. So you could have a fairly low disease prevalence like this one, 5%. And 52% is actually an okay number. It doesn't sound great. It's only a little more than a coin flip that you're getting the right answer. But that's because the specificity for this model was pretty good. Normally, I would expect a lower positive predictive value with 5%. Then a negative predictive value is also related to disease sensitivity. That number, 99%, I should have shown you a few more decimal points because it's really the decimal points that are important. But the sensitivity of the model was lower than what was predicted. And so that model decimal point is going to be a little different than the negative predictive value from the FDA clearance statistics. All right, let's go to step 2. Does AI enhance detection? Now, this is something that helps us determine if the model is going to be worthwhile. And what we call this is the EDR, or enhanced detection rate. And I'd recommend that all of you guys, when you're looking at a model, you calculate this statistic. Very easy to calculate. Look at the total number of AI findings or positive findings detected, both through the AI and the radiologist. In this case, there were 51 aneurysms in about our 1,000 cases. Out of those, how many did the RAD detect? Well, the RAD detected 41. If you take that as a percentage, there were 10 additional cases that the AI detected that the RAD didn't. 10 over 41 gives us an enhanced detection rate of 24%. So if you could optimally put the AI sensitivity in with the RAD sensitivity, we will improve the sensitivity of the system by 24%. That is massive. 24%, not just more individual findings on one case, but more patients with these findings. You're detecting 24% more brain aneurysms, and that's really helpful for the patient. Step number 3, find the wow cases. These are the things that help when you're deploying the study to make sure that your radiologists don't just dismiss it. Get them excited, right? These are all change management processes. When you roll out an AI tool, people don't just consume it, and they don't consume it properly. You have to get them excited and use change management theory. So show them some cases that they might have missed or that they would be impressed by the AI for. So here's a 74-year-old female, acute neurodeficit, stroke suspected. On the left is the axial CTA image. It's just one slice. Hard to see on this that there's a brain aneurysm, but the AI picked it up on the axials. If you look at it on the sagittals, it's a lot easier to see. But this is a case where it's very easy, and we found a lot of radiologists miss these inline aneurysms because they're concentrating a little more on the axials in the supraclinoid region, and this was a 5-millimeter aneurysm. There were several of them that we found in our cases. So we show these to our RADs. These are things that RADs actually miss that the AI found. Great. That gets them excited about it. Here's that same case with the pica aneurysm. Again, 2 of these cases were found in our subset of 1,000 studies. We show these to our radiologists to get them to understand how the AI is working and also get them excited about using it. Step 4, categorize the false positives, right? 52% positive predictive value. There's going to be a lot of false positives. Do all of the false positives matter equally? Well, no, some of them that are easy to dismiss, less relevant. The way that you manage through the other ones is you set the radiologist's expectation. Don't just tell them that it's going to miss stuff. Tell them what it's going to miss. So we go in, when we look at those 1,000 cases, we look at all the times that the AI overcalled something. We try to categorize them into the different categories. And we use this to educate our RADs so that they are setting expectations appropriately. If you show a RAD that the AI is calling the vein of Galen a brain aneurysm, they're going to start dismissing the AI. So even when it's right, they're going to start undercalling things. You need to set expectations in advance, and you need to give them some categories for those expectations. Then you have to balance, ultimately, the positive predictive value. It's not going to be super high because the prevalence of findings is not going to be that high. So balance that between all of these great calls and make your decision. So in this case, real world performance was pretty good. AI really enhanced the detection, 24% extra brain aneurysms, patients with brain aneurysms. There were a good number of wow cases, and that's because the sensitivity of the model was good enough. And then false positives, while they were common, we could summarize them and teach radiologists to dismiss them. So we decided to move forward. We did roll this out. Here's another example, and I'll go through this one faster. So this was one for pneumothorax on chest X-ray. This is analyzing the frontal view of a chest X-ray for adults, evaluate model performance, FDA statistics, and then our statistics. So our real world information is a little bit different. So way more cases analyzed because the prevalence of disease is so much smaller. We had to look at a ton of cases. And with that, your positive and negative predictive values, positive predictive value, 34%. Well, that's a lot because the prevalence of disease is pretty low. And sensitivity was also lower than the sensitivity that was showcased. So already we're starting to question how much are we going to find here. Now, going back, let me just skip this one and look at step number 2. Did AI enhance detection? So looking at the total number of cases that were detected by the RAD and the AI, well, the AI detected 0 cases that we didn't detect. 0. So no additional help means that the enhanced detection rate is 0. If I'm going to roll out a model, it's got to have a positive enhanced detection rate. Just the fact that it finds 51 pneumothoraces on its own, if those are pneumothoraces that we found as RADs, this is not helpful. And so when you're looking at the statistics and it says, oh, my model's just as good as a radiologist, we'll figure out what kind of cases it's picking up. Is it actually picking up anything that's different than the RAD would have picked up? Because if it's not, we don't care how good it is. This one was not good enough. All right, wow cases, step number 3, there weren't any, right? If it's not finding anything extra, then you're not going to find any. And then, in this case, positive predictive value low, no wow cases, right? That scale is tipping in the wrong direction. Skip to, and then pitfalls. AI had a few pitfalls. Number 1, actually, skip this one. Yeah, number 1 was that AI had a bunch of false positives, and some of the false positives were, although we could categorize them, they're difficult for a RAD to adjudicate. I mean, we look at skin folds versus the visceral pleural line of a pneumothorax, and we think about those a couple times. Orchestration errors is something we can talk about another time. That's really difficult to explain to a radiologist, an orchestration error. These were tough ones. And then they also had false negatives, 17 of them in our cases, and one of them was really big. In fact, here's that one, 19-year-old female with chest pain. And in this case, a really large left-sided pneumothorax. Here's the CT that shows you that pneumothorax. A RAD sees an AI missing this, they're not going to ever trust the model again, right? Just one of these big cases, and no one's going to trust the model. Okay, so summarize and decide. All 4 not looking so good. We decided not to roll this out. This is an FDA cleared model that we are not using. All right, so there's 5 things that we look at for model performance: performance statistics, enhanced detection rate, wow cases, AI pitfalls, and then we make our summarization and decide. There are a few more high-level things that we look at, and maybe I'll just go through a couple. I may skip some of these slides because I know we're at time, or we're getting 2 minutes away from time, but I just want to give you a hint into, you can do that and be great. You're going to be far ahead of the industry, but there are a couple of other things that we could get into. So remember that positive predictive value, which is also precision, that is something that we look at really closely when you're looking from the lens of acceptance. You really want a high positive predictive value. You're not always going to get that, but certainly you want one that's better than a coin flip. So what does that mean? Well, positive predictive value, as we said, is affected by disease prevalence. So let's take a look at what that would mean. If you graphed out a typical ROC curve, and then you looked at the 50% line, right? That's kind of where a RAD's going to maybe accept the result or not accept the result with some provisos. So let's map out what that might look like. Now, this has a positive predictive value, or a sensitivity of 90%, specificity of 99%. You could have some that are a little bit better. You could have some that are a little bit worse. But just look at what this graph looks like. At that positive predictive value of 50%, once you get below that, we're thinking RADs aren't going to accept this as much. And that's when your disease prevalence that's on the baseline is less than 1%. Once your disease prevalence is really low, less than 1%, with the accuracy of AI models as they are today, it's really hard to get a good enough positive predictive value. So what does that mean? It means things in this arena, if you're looking at something that is not common, disease prevalence of less than 1%, then you might not have a model that your RADs are going to accept. And here's where some of our models, if we look at where they are, this is where they fall. And you can see that pneumothorax fell into that area. We've rolled out all the other ones. We have not rolled out the pneumothorax. Now, you can look at it in a different way because disease prevalence affects this data. So pneumothorax, we were looking at pneumothoraces from all patients in all locations, and that's where the positive predictive value was 34%. But let's say we split that up and we said, what is the disease prevalence in the ED patients? If we only looked at them, or outpatients or inpatients, they all have very different disease prevalences. Once you get to an inpatient population, the prevalence of pneumothorax is much higher. You could, with that, just roll out your pneumothorax model on inpatients because you're going to have a much higher positive predictive value. In this case, 72%. This is our data if we look just at our inpatient data. And so we could have rolled out this model just on inpatients, and RADS probably would have accepted that. So another way to think about it, you can move your pneumothorax when you're just looking at inpatients up higher, and that could be accepted. I'm going to skip fracture model was the same, and we actually decided to roll that out. I'm going to skip this one here. Let me go to the second piece, which is the enhanced detection rate. I told you a little bit about enhanced detection rate. This is another component of the enhanced detection rate that affects RAD acceptance and engagement. So going back to our statistics, we look at the number of cases that a RAD detected, the number of cases that the AI detected that were beyond what the RAD detected, and we figure out what the enhanced detection rate is. So here we are. Extra aneurysms, 10 extra aneurysms detected out of the 41 that the RAD detected. If they increased it by 10, they would have had a 24% enhanced detection rate. There is one other way to look at this data. Instead of looking at your number of radiologists detected aneurysms, look at the total number of patients. Sorry, I put the box in the wrong place. If you look at your total number of patients, which is 968, you say, well, AI found 10 extra aneurysms out of that almost 1,000 cases. That gives you an absolute detection rate, enhanced detection rate of 1%. Now, absolute enhanced detection rate, what does that mean? Here's a list in order of our enhanced detection rate, relative enhanced detection rate. That's the amount that the AI is going to help with sensitivity of the radiologist. And you can see rib fracture, huge amount, intra-abdominal free gas doesn't help quite as much. Now, if you look at the relative rate based on the total number of patients that are out there, that gives you a very different graph. And what does this graph mean? This graph tells you how long does it take for a radiologist to get an exam where there's a positive finding that they wouldn't have found. This is what we call the absolute enhanced detection rate. And you can see that different models will produce the results more or less quickly. If I put this into a graph, this is the same as that how many scans do you need for a radiologist to find a finding that the AI helped them with? And if you get to C-spine fracture, it's almost 600 studies. You have to see almost 600 C-spine CTs before you get one that the AI would have helped you find that you wouldn't have otherwise found. That helps us understand how the RADs are going to accept these models. It's going to take them a few, like weeks maybe, depending on how many of these they read, to find anything that helped them. And that means they're not going to think the model is very good. But something like rib fracture, it's less than 100 exams on a CT of the chest or abdomen. We could get through that in a day or two. So in a day or two, you're already going to find that the rib fracture is helping you. But a C-spine fracture, it's going to take you maybe weeks. That gives you an idea of how much the RADs are going to accept this or not, and that's really helpful. Another last way is what we call the gain to pain ratio. And this, again, is going to affect your RAD acceptance and engagement. Gain to pain ratio is how much benefit do you get? What's your enhanced detection rate? How many cases are there that they're improving detection versus how frustrating is it? How many false positives are you getting? And if you just create this fraction, you get a really interesting number. Now, wow cases are going to fall into those enhanced detection rates. So those are all the great things on the top, and on the bottom, all the negative things. If this number is over 1, then your gain is higher than your pain. So anything in this case that is above the line is going to be something that RADs are going to be happy with because there's more benefit to them than there is a deficit. Anything below the line is going to be a little bit more difficult. And this is important to know. It doesn't mean you're not going to roll out the things below the line, but it means you're going to have to do more education to make sure the RADs understand and set expectations appropriately. So we actually, talked to you about our 5-step process. It can get a little more complicated when you start using these other components. And this is actually what we're looking at. It is still 5 steps, but we're looking also, is the positive predictive value over 50%? Is the enhanced detection rate over 0? Looking at making sure that there's sufficient clinical impact, looking at the gain to pain ratio. And if any of these are not satisfied, doesn't mean you absolutely don't roll them out. You might need another reason to roll them out. So all of those things that were below the gain to pain ratio, like the intra-abdominal free gas, we rolled that out because there's a massive amount of medical malpractice avoidance, and that helps our radiologists and it helps our patients. For brain aneurysms, that was below the line too, but they have a really big clinical impact. The outpatient rib fractures, we rolled them out, but they actually, why do we roll them out? Because they have a really high enhanced detection rate. The enhanced detection rate, and that was over 300%. So there can be reasons why you roll these things out, but you need to think through what they are, because that's going to be really important when you go to train your radiologists and get them to use it appropriately. All right, that may seem really overwhelming in the end. You don't have to worry about all that enhanced stuff. Even if you just do the first 5, you are far and ahead from everyone else. And what to remember is that we need to craft our own future. We are going to, as a profession, change. We need to change, and we need to be ahead of this change so that we can drive it. Like Charles Darwin said, it's not the strongest species that survive, nor the most intelligent, although I think we are, right? Radiologists are quite intelligent group of people, but it is the one that is most responsive to change. So I'm glad you guys are all here today, because it means you're learning about this stuff and you can help us drive through this change. All right, we talked about the tech-enabled future of radiology, maybe radiologists as an information expert. We talked about some AI lessons learned and how to create some best practices. AI and RADs are better together. And hopefully now you have a little bit of a 5-step model for clinical evaluation of different AI vendors. With that, I'd like to say thank you. I don't know if we have time for questions because I went a little over, but I appreciate your time in spending with me today.
Oh, Dr. Kottler, thank you so much. That was a wow. That was a wow talk, and I think you are proving Jeffrey Hinton wrong each time he speaks up, because you show the complexity of it. So those were fantastic cases, and we appreciate your input. We do have a couple of questions. Some people are still here and say thank you very much for the talk. Actually, Mike Gaeta, an old friend. He's asking why doesn't AI evaluate in 3 planes today? Is it because it's too computationally intensive, or too slow to be effective, or what's the reasoning behind some of that?
The reasoning behind is based on what you said. It is more computationally expensive to do that, and it also requires more training. And even though we've been a few years into AI, it is still fairly early, right? We're not at that plateau of productivity. We're still fairly early on where there's consolidation in the industry, and you had to start somewhere. Much easier to start with 2D than it is with 3D. Now that we're moving into foundation models, and this is something that you guys should all pay attention to. Foundation models, generative AI is going to be our future. Its accuracy is going to replace convolutional neural networks. It's going to replace NLP. And that is even earlier on the hype curve. The only models that I've seen out there that have been trained on radiology data are also 2-dimensional. It's just where we start. There are some groups that are adding in coronals to your axial, so you pseudo get 3D, but it's a lot harder, and it's a totally different kind of training. So it takes extra effort and knowledge and experience to do that.
Great, thank you. And another question from Mike Gaeta: do you think that AI in radiology will help alleviate radiologist burnout? We're seeing a lot.
Sure. Yeah, a lot of the AI that we've deployed so far hasn't really done that. And that's because AI early on, it was mostly doing things that we're pretty good at, right? Our visual cortex is really mature. So you get like a 10% ROI or 20% ROI on your imaging exams. Where we really need help is the workflow stuff and anything related to dictating a report. We should not be dictating a report. That is a complete waste of our time. So doing any of that as we start to move into that, that's going to significantly decrease burnout. There has been some burnout decrease with the computer vision stuff too. We've noticed, not as great, but some, because it's kind of like having a buddy sitting with you that's backing you up. And that's nice to have, especially me. I do a lot of remote imaging. I'm sitting by myself all the time. So, and I loved being in the reading room with lots of people. I don't have that anymore. So you get some of that just because you're getting a little more interaction, but it's going to increase over time the more that we're deploying these, especially in the workflow, not in the imaging space, and anything to do with collecting information and reporting.
Great. And let's see, we have a question here. You're getting lots of kudos for great talk, very practical. Thank you so much, blah, blah, blah. And they're glad you started with the clinical utility and value. The question here is wondering, how would AI detection models be affected by incidentalomas? What do you do with the incidentalomas?
Yes. So first, the AI would have to be finding those specifically. And there are some AI that are looking for incidental findings, not just critical things. What do we do with them? Right now, we have population health guidelines for some of them, right? There's a lot of white papers out there that help give us information about these. I find that a lot of those, while they're helpful, they're not always based on actual data, patient outcome data. A lot of them are consensus criteria. And consensus things are good because they give us something to start with. At least we get information from experts, but they're not necessarily the be all end all. It is important to point out these incidental findings, but it's important two things. One, to know what you should do with them, like should they be followed or not? And two, to be able to tell your clinician, is this something that we think is worrisome or not worrisome? And I think what we're going to use AI for in the future is, once we gather more data from the EMR to these AI systems, we can do more prediction about what is going to happen to this patient, number one. And number two, we can also get outcome data and figure out what is the appropriate follow-up for an aneurysm. Let's not just take the size into account, which is all we're doing now, or male and female. Let's take other things into account. You know, is the patient hypertensive? Are they diabetic? Are they on certain medication? Let's get to the point where you're using personalized medicine and giving a recommendation for that specific person. We're going to be able to do that a lot more as we get more clinical data that are put into these models. And we're going to be able to do it more as we get more information out of our CT images, like radiomic data that will be looking at the wall and the thickness, et cetera, looking at disease progression over time. That's the future of where we're going. We're just not there yet.
Fantastic. And maybe just one more. I want to be respectful of your time. And that is, do you have any, do these models have any value, or what have your experience been around medical legal discussions? You mentioned you often look at your thin slices, and I'm wondering whether you actually save all the thin slice. A lot of places will send the thick for review to the workstation, and are they actually saving in perpetuity the thin slices? So what are your thoughts? And maybe we're going to have you back, because this is so much great information, but maybe a last thought about medical legal.
Yeah, there's a massive amount in this area. Let me start just with, we've done a lot of evaluation from the medical legal standpoint with our telerad practice. We work with virtual radiology, and they have a very big practice, and they've been following their med mal data for years, and their quality assurance data, right, peer review data for years. And what they found is that the medical malpractice, there are certain areas where they're getting more of that. And with those areas, they're looking at which are the ones that we could build AI models for. So I do think AI models can help decrease medical malpractice if they're in the arenas in which we're getting mostly sued. Now, they do a lot of emergent imaging, but what they found are we're missing a lot of bowel pathology, especially ischemic bowel. So they have a model for SMA occlusion. We miss SMA occlusions quite frequently. They don't happen that often, but when they happen, we often miss them. Epidural lesions, especially on non-contrast CTs that are including the spine. Epidural lesions can be, epidural hematomas can, or abscess, they don't always come with a history. They can be hard to find and they're very devastating. So there's things like that where we can build AI models to help detect findings that we're not noticing, help decrease med mal, and it also helps patient care, right? So that's important. The other parts are more things that we don't know about what's going to happen in the future, right? Like who's going to be legally liable. We are standard of care. So right now we are absolutely legally liable for everything. You take an AI result, it doesn't matter what it says. What you say is the standard of care. However, in the future, what's going to happen to that? We don't know yet. There haven't been any cases that have been adjudicated there. And once AI becomes standard of care, there's going to be all kinds of other things that we have to consider. How do we make sure that the user is properly educated? How do we make sure the AI is available? What if the AI provides a result and we're not providing the transparency about that? All of these things are going to go through the legal system. I say better safe than sorry, and just learn about it yourself. Make sure you're educating your RADs and try to proceed where the legal system is, because the legal system is going to catch up.
Fantastic. Well, we'll let you go, but we're getting comments like the greatest talk in the AI4C series. So thank you very much. We'll have to have you back because you're a wealth of information, and thank you so much, Dr. Kottler, for your presentation. Wonderful presentation. Thank you so very much.
Thank you, guys. Thanks for having me. Sorry I went over.
No, it was great. Thank you. Thank you, Nina. Fantastic. Thank you. Bye-bye.
Bye.